innovation is something that it is very important for Abbott and improving healthcare. And brain biomarkers is another example. Back in the 80s, it was the first HIV test. Then during the pandemic, all the work that you know that Abbott did with the COVID test. And now it's another new. So Abbott has a brand new test that is used in clinical practice to help physicians assess patients with mild TBI in the emergency department. Today, I'm here with Dr. Ava Puccio. She's an associate professor for the Neurological Surgery program at University of Pittsburgh. He's also the co-director of the Neurotrauma Clinical Trials Center. So these are our disclaimers. So the test and the technology that we're going to talk about today is the TBI test, which was cleared by the FDA. This is the intended use, which is for subjects that are suspected of mild TBI, meaning a GCS between 13 and 15, 18 years of age or older, and within 12 hours from injury. Now, this new technology is new in the United States. It was cleared last year. However, the technology was first cleared in Europe, and since then, the test has been implemented. And as this is a new part of the standard of care, the implementation has been slow. However, it's being very well accepted by the medical community. After the test has started their implementation, there has already been a movement to try to update the different guidelines and different consensus, not just in Europe, but most importantly, these efforts are also starting to happen in America. And by America, I just don't mean the United States of America, but most importantly, in Latin American countries as well. So some of the examples that you see here was the new French guidelines back in 2022. You can also see the Spanish consensus in 2023. And now there are other countries like Colombia and other countries in Latin America where they're also working with the Spanish counterparts in updating those consensus and guidelines in order to bring this new technology in clinical practice. This is an example, and just again reiterating, when the guidelines were updated in France back in 2022, where it was a recommendation for emergency physician doctors to use a biomarker when they are assessing these patients. In the case of Spain, which was in 2023, it is a consensus, which is even better because it's not just an effort that comes from the emergency department, but it was an effort that they included radiology, laboratory medicine, which is very important because, again, it highlights the role that you guys, the laboratory, has in the inpatient care. And all these efforts also have been implemented in other countries. And this is just showing you how these biomarkers have been implemented in other countries in Europe. This white paper that I'm showing you here in the slide, it highlights the experience of some of these hospitals. And to, not a surprise, because we know that it's a very solid product, and we're gonna talk to you about the science behind it, how everything started. What they are seeing that the sensitivity, specificity, and the negative predict value of this biomarker is even higher than what the IFU says. So, Dr. Puccio, I have a question. So, in your experience, I just want you to please tell us a bit more about this technology, how everything started, because we say that it's a new technology, right? But it's a technology, like I said, is very solid. There's a lot of years and effort that was put into it.
Sure. Hello, everybody. So I just wanted to go over some of the background of what we've been doing over the years. And as Jaime had said, everything takes a long time, unfortunately. So I've been around in the very, very beginning. But just to show you what we need in TBI. So we really need some objective measures for assessment of TBI and looking at what are we doing in our emergency room department. So We have a huge burden in our emergency department of suspected TBI. We are inefficient in our processes right now, and our physicians are a little bit over optimistic on how our patients are going to do after a mild TBI. So looking at the burden, the U.S. in the ED, we have 4 to 5 million evaluations per year. Of those, about half of them have a diagnosis of a mild TBI. We're inefficient. Everybody, because of legal reasons, usually in the U.S., is receiving a head CT scan. So of these patients, 82% of them are receiving head scans, and only 90% of those head scans are normal. Only 10% are abnormal. And then our physicians are sending our patients home thinking that everything's okay. You may have had a little bang on the head. You might have something small on the CT scan. You're going to do just fine. So our clinicians are predicting that only 4% of these patients are going to have any difficulties at 3 months. However, in reality, over or close to half of them are not back to work, back to school, back to play at 3 months. They're still having symptomology and lingering issues after a TBI. So we really do need a little bit more objective measures. So going back in time a little bit back to about 2012, I was involved in the very beginning of TRACK TBI, or Transforming Research and Clinical Knowledge. And the goal of this research consortium was to improve the diagnostics and the prognostics in traumatic brain injury. There was 3 level 1 centers. Pittsburgh was one of them. University of California, San Francisco was the coordinating center under the direction of Jeff Manley, and Baylor was our 3rd level 1 center. Mount Sinai was our rehab center. So we were looking at the whole spectrum of mild, moderate, and severe TBI. We wanted to improve the diagnostics. We collected biomarkers in these sample sets, and we wanted to make sure that we were pairing those blood biomarkers with a very curated data set that would have both imaging and that would have our outcomes. So we wanted to look at a biomarker that would be very similar to what we do in cardiac arrest. So looking at how do we assess a cardiac patient? So when a cardiac patient comes in with chest pain, they're presenting them to the ED. We're immediately getting blood biomarkers. We're looking at troponin levels. With that, we're deciding if they're negative, they're going back home. They may be receiving prescriptions. In the worst case scenario with very high levels, we're sending them to cardiac catheterization or some type of intervention. So we really wanted to use this as a correlate to get to this blood biomarker basis in our traumatic brain injury. So this goes back to showing the whole timeline. So TRACK TBI is kind of in the middle of this timeline between 2002 to 2021 with our FDA clearances from Abbott. Don't want to disregard all of the experimental TBI work that went on from 2002 to 2012, but only focusing on the patient aspect of our TRACK efforts. So when we were looking at our TRACK TBI subjects, we were looking at 3,000 patients that we enrolled. 2,700 of those were traumatic brain injury from the spectrum of mild to moderate or concussion to coma. And 30 of those were orthopedic controls, which are super important to make sure that we also had those followed up and those data also curated. So the goals was to improve the diagnostic and the classification, also to improve our outcome assessment on how we're assessing these patients at 3 months or 6 months after injury. Also to identify the health and economical impact of mild TBI, how much we're getting CT scans, economics, loss of wages, etc., from our patients not returning back to work or play. And then also creating this information commons to promote collaboration and acceleration of TBI research. And this part is super important too, so that we have a curated data set that once again we can compare to our blood biomarkers. These were our 18 study sites that enrolled patients. So this lists all of those that were involved in both the blood curation and enrolling patients. San Diego was our unbiased statistical group that was blinded to the data rather. These are all of our investigators at these individual centers. So this just shows the wealth of the originals that enrolled all of the patients. Each of those have a team that is back behind it. So a huge effort in this consortium. At the same time that we were enrolling patients in TRACK TBI, we were also involved in Pittsburgh in the efforts of a study called ALERT TBI. And ALERT TBI was looking at the 2 biomarkers of interest in a panel that they developed for glial fibrillary acidic protein, GFAP, which is looking at astrocytic injury, and ubiquitin C-terminal hydrolase 1, or UCHL1, which is looking at axonal injury. So this subject population enrolled all comers from the ED. We were looking at 1,977 of these individuals that were enrolled. But once again, most of them had negative CT scans. Less than 10% had a positive CT scan in 125 participants. And then looking at the differences in their biomarkers, we were able to show a sensitivity of the blood test to a positive CT scan with an AUC of 0.976. So very high sensitivity. This data was then presented to the FDA in 2018. And we were very excited to then have the first blood test to assist in the predicting of intracranial lesions on a CT scan. So these patients' blood markers were taken within 12 hours of injury, and the indication was for this FDA clearance for the biomarkers within 12 hours of injury. So the downside of this was that even though we were excited to have this, many physicians did say, well, we could get a CT scan faster than you can develop this blood test. So the test did take 3 to 4 hours in duration for the platform. Abbott purchased the license for these biomarkers, and they improved it in 2 ways. They increased the sensitivity, and then they decreased the time to analyze. So in 2019, the FDA granted clearance for the point-of-care blood test for concussions. And then just recently, about a year ago, Abbott received the 3rd FDA clearance for the first commercially available lab-based blood test to help evaluate concussion in the ED.
Yeah. Thank you, Ava. That's so interesting. I think, it's not easy to summarize the work of over 10 years and hundreds of people, right? And actually today we're very lucky that some of those team members from R&D are here because it was not an easy task. It was not just getting a product and launching it later on to be used in our platforms, right? It is a product that was maximized, and it's a better product because, again, one of the most important things for Abbott is create technology that will be valuable for to improve patient care. And some of those members of the R&D team are here with us today. So we are very fortunate to have them, like Dr. Daweiler right there in the back, and others from the R&D team. So, Ava, I have a question. So now that, yes, we have a test, laboratory medicine is here, why is it so important to have this objective technology, which, as you said before, it is crucial because it did not exist? How do you see that this new technology be of use and value in clinical practice?
One very important detail was not only did it go from 3 to 4 hours, but it's down to 15 minutes for the test. So I totally skipped that piece. But 15 minutes is a very important component.
Right.
So we've been looking at, this is some of the data that we also received from the TRACK TBI data set. So we do have some cutoffs. I'm looking at the median GFAP. So we're hoping that this is going to be implemented in our EDs and aid in the diagnosis of our TBI patients. So looking at these cutoff values, if somebody would come in and have a value of 1,200 picograms per milliliters of GFAP, we would think that, you know what, they're most likely going to have a positive CT scan. And sure enough, with this particular value, this is a patient scan that we had shown that had positive intracranial injury. In contrast, though, somebody came in with a 200 picogram blood biomarker level. Looking at that, they're not quite at the healthy control cutoff. And all of our patients that we enrolled in Track TBI, we were hoping to get them back in for a 2-week MRI. When they came back for the 2-week MRI, this particular individual had a positive MRI finding, even though their CT was negative. So I do think that it is very sensitive here. When we're looking at another patient that came in with 50 picograms per milliliter, we could be pretty confident that they are going to have a negative CT, negative MRI, and sure enough, they did not. Is this just, how was we looking at it in our busy EDs is one of your questions that you had. So those are a few examples. But as we've seen in our COVID times and even after our COVID times, many of our EDs are being overrun, and we have a lot of patients that are coming in. A lot of our beds are full, and we just have patients lining up in our hallways, unfortunately. So I do see that a quick biomarker would help us to triage patients. So for instance, this is one other instance. We don't want to miss also those very, very severe patients. We had a patient that came in that had levels of greater than 30,000. So those patients, are obviously going to have a huge CT abnormalities, but not only that, they're most likely going to need to have an emergent neurosurgical procedure performed, or a decompressive craniectomy, for example. So in those instances, I do think that those high levels need to be looked at too. So for instance, a patient that comes in, we usually get report from the emergency personnel in the field. So we'll get something like this: 46-year-old, status post-fall plus loss of consciousness, intubated in the field. Really has an image of a severe traumatic brain injury. So we're very concerned about that individual. Glasgow coma score is 17. They're not following commands. They're in the coma range. However, this person had a normal CT scan. Looking at the blood biomarker level, it was within the healthy control range, but their blood alcohol level was very, very high. So we can be very confident that this patient is going to go to the ICU, but is going to be probably very quickly extubated in 24 hours. However, flipping just a little bit to have a different CT scan, same kind of image that we may be receiving from our paramedics, but now they have a positive CT scan, subarachnoid hemorrhage, subdural hemorrhage, contusion, high GFAP. This person's not going to be extubated within the next 24 hours and is going to have a little bit longer course in our ICU. So that's kind of examples that we're showing that how we feel it's going to be implemented.
Okay, next slide.
Is the
Yeah. So now that we have this claim and we understand that definitely this is a very useful tool for physicians, right? Because it brings back objectivity to the work that they do in the emergency department. How do you see this evolving within the research world, and how other biomarkers, how have these biomarkers been explored that could potentially work, or some of them that might not have worked?
Right. Well, you had mentioned in the beginning that Scandinavia and the recent French guidelines are using S100 beta. We were very concerned that S100 beta is not specific to the brain. So we wanted to look at those values too. So we did look at a comparison in Track TBI of looking at the S100 beta in GFAP and UCHL1. And GFAP and ECHL1 is much more sensitive, specific to the TBI, because those are the blood biomarkers that are coming from the brain. S100 beta is a concern because it can also be released from skeletal damage or injury. So you can have orthopedic controls that have release of S100 beta. And then also melanocytes also release S100 beta. So you are concerned with the darker pigmentation of some patients may have higher normal values of S100 beta and make it a little bit difficult to compare. So other research efforts that we've been doing in Track TBI is also looking at GFAP as a prognostic biomarker, which kind of makes sense if you're looking at higher initial levels of GFAP is correlating to higher damage that you see on CT scans, and then that in turn leads to a poorer 6-month outcome.
Right.
We've also wanted to look at trajectories of how the GFAP and biomarkers may change in TBI. We did look at the 24-hour after injury, day 1, day 3 in those hospitalized patients, and then all the way out to 2 weeks. So we are looking further out at the different trajectories of how the biomarkers may change in time. So looking at a different patient population once again, and just kind of giving a correlate. So looking at prostate-specific antigen that we've seen through the years really help the PSA levels helping in the cancer world. So this is obviously over against 20 years, but looking at this data, PSA levels really have revolutionized prostate cancer. So they've seen like a death decline of prostate cancer about 50%, which is awesome. So we're seeing that biomarker really assist patients. But when you look at the U.S. incidence of prostate cancer, there's only 192,000 prostate cancer. When you look back at some of the statistics that we had before, the annual U.S. incidence of TBI is close to 3 million.
Wow.
So we're really hoping that these biomarkers can help a lot of our patients through the years. And this is our team in Pittsburgh, so can't do this alone. So we have a lot of staff that helps us, along with all the other sites that we have.
Great.
So that's all.
Thank you so much, Ava. I really appreciate all you coming here, and thank you for all that wonderful information that you're providing us. Are there any questions from the audience?
I believe this is an ideal test for the emergency room. And how do you see, like, if it is a laboratory-based test, and what would the turnaround time be? That's question number 1. Question number 2 is there any biomarker that could differentiate types of strokes like ischemic or hemorrhagic?
So 15 minutes on the platform. We have not looked at the stroke in our population. I'm specifically for traumatic brain injury, but I do think that there is an expansion that can be looked for other populations that may have. The GFAP is looking at the astrocytic damage, and the UCHL1 is neuronal damage.
Hi. Is this always looked at in conjunction with CT? Would we ever use these biomarkers and not have to do a CT scan of the head?
In place of a CT scan, you would?
Yeah.
I think it could come to that point. I mean, we could definitely save, the economics of the CT scan, the cost of the CT scan, and also the radiation risk. I do think that is going to take a little bit of time to get to that point, but I do think that that's where the research and the development of the biomarkers will head to.
Yeah. So the current claim, to your point, it's for the rule out of CT scans, right? You are ruling out the presence of intracranial lesions visible in a CT scan. Now, what you're referring to, it's probably a ruling test, right? A ruling claim. We are not there yet, but I mean, there is research that is being done.
Oh, good.
All right.
That's good.
All right. Thank you again.
Thanks for everyone's attention.
Thank you for your
All
time.
right.
Thank you, Ava.
Mm-hmm.